So without further ado, I'll turn things over to our pathology colleagues. I believe first up is David and Ram, if I'm correct.
Thanks, Matt, and thanks, Jonathan, for that awesome overview. Super exciting. Hopefully we can all participate in this project. So the first case is a really interesting case that David and I saw together with Dr. Mariuma. And so I'll hand it over to David to present the case.
Thank you, Dr. Kailash. I will start sharing the screen and just give me a thumbs up if you can see it.
Yeah, we can see your slides, David. Thank you.
Perfect. Thank you. Well, welcome. Thank you. We'll get started without further ado. First, the clinical presentation by Dr. Mariuma, and then we will discuss briefly what we know at this point about this case. Dr. Mariuma.
Yes. Hey, everyone. All right, so this is a patient that came to my clinic a couple months ago, back in September. So he's 55, and he had already seen a nephrologist for gross hematuria and worsening kidney function. He had a history of atrial fibrillation with an ablation and a aortic and pulmonic valve replacements for stenosis, but those had been pretty remote. Everything had been stable from a cardiac standpoint. He was on warfarin, denied any history of kidney disease, and there were creatinines available going back, showing a baseline creatinine of about 1.1 to 1.2. He received the Johnson & Johnson vaccine on July 14th, and a few days later, he developed painless gross hematuria. He went to an urgent care for it, and his creatinine was found to be 2.79. I guess next slide. So he was sent to a urologist and a nephrologist. The urologist performed a CT, and there were no stones, no evidence of malignancy. He had a complete urological workup with a cystoscopy that was unremarkable. Urine culture was negative. He saw a nephrologist at another institution who basically chalked it up to RBC-related toxicity leading to ATN. He had noted dysmorphic RBCs, and he felt that those were likely due to valve replacement, and those were changes just secondary to that. So he came to me for a second opinion. He denied any recurrent episodes of gross hematuria, and he did say that he's had chronic bilateral flank pains that were nothing really significant, but he otherwise didn't really have any other symptoms, and he denied any use of frequent use of NSAIDs. Next slide. So for medications, he wasn't on much, just bisoprolol, warfarin. Denied any herbals, naturopathic, homeopathic products. He had no family history of renal disease, no drug use, no smoking, just social alcohol use. Next slide. So these were the labs now 2 months after the initial events when I saw him. So his renal function panel, electrolytes were okay, but notable for a BUN of 43 and a creatinine of 2.29. His hemoglobin was slightly low at 12.9 with a hematocrit of 39, normal platelets. Smear revealed no hemolysis, no blasts or anything like that either. His UA did show RBCs, but no significant proteinuria. On microscopy, I saw numerous dysmorphic appearing RBCs, but I didn't see any casts, crystals, or anything else of note. No WBCs either. So serological workup, some of this was done by his other nephrologist, some of this was done by me. So essentially, everything really came out negative: hepatitis, ANA, no monoclonal component. Complements were normal, though kind of on the lower end of normal. ANCAs were negative. Anti-GBM antibodies were negative. In terms of imaging, ultrasound just showed increased echogenicity and some simple cysts. So now, 2 months after I initially saw him, his creatinine remained in the 2.2s, and he remained with hematuria and dysmorphic RBCs. So basically, we did a biopsy.
Thank you. Our biopsy showed the following findings. It's we got 2 cores with a pretty excellent sample, about 25 glomeruli. This shows this low power view, a mild to moderate interstitial fibrosis and degree of tubular atrophy. In this other slide, you can see an area of a more well-preserved renal parenchyma, and these 2 glomeruli that do not show overt features of activity except by endocapillary hypercellularity, which actually shows better on this next slide, next 2 slides. So in this one, you can, if we can center attention here on this capillary loop, you see this endothelial cell that is very prominent. Almost 3/4 of the entire lumen is occupied by that swollen cells in here. And then we start seeing that event frequently. But we make use of these other stains that we have, and this allows us to see it even more easily. And we can see that endocapillary hypercellularity is the predominant finding in the glomeruli. We don't have mesangial hypercellularity. We don't have crescents. At this point, but the basement membranes are pretty much normal in this glomerulus specific. Now we move on to another glomerulus, and we have this area where I have signal here with this circle is this pink material, eosinophilic, that is consistent with a segmental necrosis. This segmental necrotizing lesion is basically in the background of this endocapillary hypercellularity in this glomerulus, no other change in the basement membranes. We move on to different glomerulus. This glomerulus has a very small cellular crescent. You see here the reactive looking epithelial cells, is prominent podocyte reabsorption droplets, protein reabsorption droplets. In this case, we also see some cellular debris in apoptotic bodies, these dense, dark spots in this area. This next glomerulus shows a very interesting finding. We see here, if you follow this line, it's this glomerular basement membrane, and it stops. Apologize, it stops here. And it should continue all the way around this area. But obviously there's a huge gap here from this area to this area. And there's an incipient or very early crescent being developed at this point, with this creating this cellular attachment. There's cellular debris and this apoptotic debris in this area. So this is a very focal finding. From the 25 to 29 glomerulus, only 1 shows cellular crescents, only 1 show the segmental necrosis, and in these different glomerulus that we find this GBM area of discontinuity. So based on those findings, we continue with IF with those findings in mind, and we go and find a linear staining, not too strong, but clearly positive staining for IgG in the basement membrane. So we rated the intensity for this IgG staining as 2+, and slightly more weak linear staining for kappa only, because lambda is negative. So we have an IgG kappa staining of the glomeruli. Based on this finding, we perform IgG subtyping, and to our surprise, we found that there was a subclass restriction. It was only positive for IgG1, but obviously not for IgG2, 3, or 4, as you can see on these images. Now we move on to the electron microscopy findings. And basically what we found in the sample for electron microscopy was a confirmation of the endocapillary pattern of injury that we found by light microscopy. And you can see our basement membrane in this area does not show significant alteration, no increased thickness or thinning. The podocyte food processes are relatively well preserved in this area. And what is prominent here is the amount of cells. Some of them are inflammatory cells. If the endothelial cell also is swollen, so the entire lumen is almost occupied by these inflammatory cells. So that was the most prominent finding by electron microscopy. If somebody wanted to chime in quickly and say what's your thought regarding the pathologic diagnosis before we move on.
Was C3 positive?
C3 was negative.
So it seems patient has IgG kappa.
IgG1 kappa. IgG1 kappa.
Around the basement membrane, like more of an atypical anti-GBM.
That's a great thought, and that's probably where we are going. So our final diagnosis was an atypical anti-GBM nephritis characterized by a focally necrotizing and chronic glomerulonephritis that we have seen in one glomerulus, and a monotypic linear staining of glomerular basement membranes for IgG kappa that was related to the first diagnosis. Also a patchy interstitial nephritis secondary to the first diagnosis, and a background of nephrosclerosis with a mild to moderate degree of tubular atrophy and interstitial fibrosis and mild arterial sclerosis. So why are we discussing this today? First of all, especially for this type of cases where we have a negative anti-GBM in serum, it may be a diagnostic pitfall also for the pathologist. And I want to discuss this as a potential new side effect of COVID-19 vaccination. And I put these 3 question marks because I will make my point here and why this can be also questionable. This is a first case that was reported by some authors, including somebody at Columbia University, where they had this patient who presented a worsening kidney function after a viral respiratory infection. And basically what they show is an endocapillary pattern of injury. It's a little bit dark, but you can see inflammatory cells abundant inside the capillary loops of these glomerulus. And with this staining, they demonstrated the influx of monocytes in the glomerulus. Now, this patient had an indolent course and had 9 years after the first presentation, had a follow-up, which basically showed the same findings, an endocapillary pattern of injury. You can see here that had a few glomeruli that show no fibrinoid necrosis or crescents, but show a little bit of chronicity. So this was the first report of an anti-GBM disease with linear GBM staining for monoclonal IgG. This is what's special about this case. This is IgG and panel H, and in panel L, this is kappa, and this is lambda, which is completely negative. So based on that, there was a series of cases published from authors from Mayo Clinic that show the clinical pathologic features of anti-GBM, atypical anti-GBM, and which importantly, they show that they have a heterogeneous presentation histologically, but including endocapillary. So this fits very well with the findings in our case. That's the main glomerular change that we find. although they can find mesangial hypercellularity or MPGN pattern. Now, importantly is absence of diffuse crescentic GN. So I would say, in other words, more like focal or focal finding of crescentic GN. And that's in our case, presenting that way. And by immunofluorescence, we have half of the cases that may present with monotypic IgG staining. So that's not unheard of in a typical anti-GBM. So the main difference in this case, obviously typical anti-GBM, it's way more frequent. It presents with rapidly progressive glomerulonephritis against a typical anti-GBM that presents a slowly progressive renal insufficiency. That first case was a follow-up of 9 years and may present with hematuria and heavy proteinuria. No lung involvement, important in a typical anti-GBM as an indolent or more chronic course, is a good renal outcome and also a good patient outcome. And this is one of the cases from the same paper I just mentioned that it just illustrating the findings that were described. This is an endocapillary pattern of injury demonstrated on this case with an IgG lambda staining only and kappa negative. Now, this was a larger cohort that from authors from China, and they had a case number of 60 patients. That most important here is that the overall survival, the renal survival rate was pretty good. Actually, it became stable after about 40 months. Now, we bring this question here, given the sudden onset of the symptoms after the COVID-19 vaccination, that was about 2 weeks. Could this be a rare adverse effect? We have this paper published recently from the first author is Tiffany Kaza, which showed glomerular disease in a temporal association with SARS-CoV-2 vaccination. They did 29 cases where this there was this close temporal association with SARS-CoV-2 immunization. And the predominant finding, or the most common disease manifestation in this case, is IgA nephropathy. And they hypothesized that IgA nephropathy in patients that it could be triggered in patients who produce galactose deficient IgA antibodies. And this has been reported in people that received the influenza vaccine. But they emphasize that the causality of all these findings it's really unclear. There's only a temporal relationship, and importantly, there's no typical anti-GBM disease on these case series. Now, the incidence of glomerular disease in response to the vaccination is really unknown, but they analyzed in their private practice that there was no overall increase in the incidence of glomerular disease when they compare with the 2 years prior to the COVID-19 pandemic. Now, we had this other paper, and these authors checked this, they raised this question, COVID-19 vaccination followed by activation of glomerular disease, does association equal causation? So we can say no, but they presented this case, and there's some case of anti-GBM that was triggered after a vaccination with Moderna vaccine, but not a typical anti-GBM. This was a classic anti-GBM disease, which presented as a de novo, where it was treated as usual with no recovery in the follow-up. Now, the same authors present different ideas. I'll go just briefly over them. They emphasize again on clear mechanism of injury, and mRNA vaccines may induce a more potent immune response than inactivated virus vaccines. They think that they may be secondary to molecular mimicry, but obviously this hasn't been explained yet. And most patients who developed glomerular disease were not on immunosuppression. And it's a well-known fact that people receiving immunosuppressants do not respond well to the vaccines in regards to the antibody production. And the authors of this paper support, or this small article, supported management strategy consistent with the conventional therapy of glomerular diseases not associated with vaccination, including the use of immunosuppression. Now, this other case that I found related to vaccination was diffuse crescentic GN, not a typical anti-GBM, but presented as diffuse crescentic GN with 100% active cellular crescents and no significant chronic injury that show IgG and granular mesangial staining for IgA in addition to the anti-GBM disease. So in this case, the anti-GBM titers obviously were positive, and it was a case of usual anti-GBM nephritis, not atypical. And a second paper that I just actually found only 2 cases published regarding anti-GBM disease related to vaccination. Most of them are related to minimal change disease, IgA nephropathy, and some other entities, but rarely is mentioned anti-GBM on this type of cases. So this is a case from Singapore where they present this case of a 60-something-year-old female and had the, well, I'm sorry, I forgot which vaccine this person received, but either way, she presented with crescents. You can see it pretty prominent, almost circumferential, and percent IgG and lambda positivity, although the authors do not mention specifically what happened with kappa, so that will be a question to answer later. But either way, the anti-GBM in serum was indeterminate. The titer was in the range of not negative, not positive, but did not show pulmonary involvement. So as a conclusion, anti-GBM, including atypical anti-GBM disease, can be raised as a potential vaccination side effect. Now, obviously, we know that there's reporting bias, and we don't know the true incidence of glomerular disease. So this may be a coincidental finding. We don't know until we know the mechanism of disease. So at this point, there's not enough evidence to bring the causality vaccine / glomerulonephritis. So it's important to follow up close side effects of the vaccine, and obviously the benefits will outweigh the risk on this case. So this is extremely rare case. If you have any questions, let me know.
David, the absence of the antibody in the sera, is that just because the immunoassay is insensitive at that level, or?
There is a question about the sensitivity of that. Even in cases where we have a, typical, let's just say that my typical anti-GBM disease, we may have cases of negative serum test, but no, I don't know exactly the number at the top of my head when it comes to sensitivity of this assay.
Most likely a different epitope that is being targeted in the atypical anti-GBM that's being missed in the conventional assays used to test for anti-GBM disease. So that was an excellent presentation, David. Yeah, so the key points here, of course, are for this atypical anti-GBM disease. I mean, anti-GBM disease itself is rare, right? But this is even, a smaller subset of that. And this case had all the classic features of, a negativity for anti-GBM antibodies in the serum, kind of a more indolent course with focally necrotizing crescentic presentation, and kind of an endocapillary proliferative histology, and even IgG1 kappa restriction by immunofluorescence. So the second question is, of course, as David had a very nice overview of the literature, is can we blame this on the vaccine? And I think, all the studies have shown that there's no necessarily increased incidence of these glomerular diseases before and after the vaccination campaign. So when we're immunizing so many individuals, are we just picking up, by coincidence, some of these glomerular diseases? And it's hard to do it when we have such small numbers as well.
I mean, it's a related question, Ram. That is my thought as well. But there are also reports of relapse of glomerular diseases along with vaccine, and that's a clinical question as much as a pathological question. Like, anyone has thoughts on that?
Yeah, that's a great question. So, I mean, we can't exclude that the vaccination is not triggering a relapse of the glomerular disease. I think that's certainly valid. And I think probably the strongest case of that is with IgA nephropathy, right? And so there's clear associations with infections or classic IgA nephropathy, and also influenza immunizations triggering IgA nephropathy. So there's probably some real biology there that these vaccinations are boosting the immune response and triggering a relapse or a de novo IgA nephropathy in susceptible individuals. It's just hard to connect the chain of causality there. But in some of these other more rare diseases, it's a little harder to explain, but we can't exclude it. Minimal change disease is actually another example, right? I mean, we know that there's an immune component to it, and there's a possibility of immune stimulation triggering minimal change disease as well.
Yeah, that was a very interesting case, David and Ram. I saw that Ashley asked the same comment in the chat box about the value for indirect immunofluorescence with increation of patient serum, and I agree, especially since this was a monoclonal, although it has been reported as David showed, but since when we're dealing with monoclonal immunoglobulins, there is of course, I mean, these two things. Okay, are these depositing somehow, or when we say anti-GBM glomerulonephritis, there is really that immunoglobulin is reacting against something in the glomerular basement membrane. So if the serum assay was negative, I think that indirect immunofluorescence would be helpful to stamp it as really anti-GBM glomerulonephritis. And most of the atypical ones are also IgG4, but I agree. I mean, again, we have, as it was shown, there have been rare cases with IgG1 as well.
Yeah, even that first case, right? That the incident case reported from Vivet's group at Columbia was an IgG1 kappa, similar to ours. Yeah, I think there would be value in doing the indirect immunofluorescence in the serum, and we can certainly take that up with Dr. Marioma as well. But yeah, it fits very classically with what has been reported for this entity so far. Any other questions? If not, I think we can move to the next presentation. Actually, there's one last question by Nikolai. The J&J is practically an adenovirus infection, any other association of atypical anti-GBM with viral infections. And yeah, so that very first incident case was a post-viral kind of presentation. And so, yeah, so there's probably some merit in there to that idea. But again, these are extremely rare. I mean, when we talk about anti-GBM disease, typical anti-GBM disease, we're talking about maybe a 1 in a million kind of incidence. And of those, maybe 10% are going to be this kind of entity. So we're really talking about a very rare disease presentation to try to understand the epidemiology. Great. Okay, so I think we should probably move to the next.
I just wanted to add on, this is also the only case I could find that didn't have significant proteinuria. So I don't know what to make of that.
Yeah, I'm not sure again for a single case. Yeah.
Okay, why don't we move on to case 2? And Dr. Rivera is going to start with the clinical presentation here. If I can get it to advance. There we go. Everyone see that?
Kelly, do you want to put it on presentation mode?
Okay, let me try to get that. There. All right, how's that?
Yeah, it looks good. So thanks for asking me to present the clinical history here. So this is a 58-year-old female who received a living related kidney transplant in 2005. And she presents to me with worsening hypertension and an increase in her proteinuria. So she has a long kidney history, much of which took place many years before I was ever in medical school. So she was diagnosed with what was described as an MPGN type 1 in 1989. A biopsy was done outside of the UW system, treated at that time with an ACE inhibitor and aspirin. There was, per report, a broad workup that was done at that time for etiologies, and nothing was found. She was first seen within the UW system in 1994 when she moved to Washington State. At that time, her creatinine was 1.6. She had presented because she developed an increase in her in edema in her legs. A 24-hour protein was done that showed 8 grams of protein, and her provider at the time treated her with a number of months of higher dose prednisone, which was successful in reducing her proteinuria back to sort of a baseline of around 2 grams. In 2003, she presented with an episode of acute kidney injury where her creatinine escalated to 10, her proteinuria went up to 10 grams, and also had a worsening in her hypertension. A native kidney biopsy was done at the time that confirmed, again, this MPGN, and there were some focal crescents, but a lot of chronic features as well. A trial was done again of escalating her prednisone up to 60 milligrams a day for a number of months. This was not effective, and unfortunately she developed kidney failure in 2004, was started on peritoneal dialysis. She then received a living related kidney transplant from her sister in 2005. In 2007, she had another episode of acute kidney injury. This time her creatinine increased from a baseline of 1.3 up to 1.9. A transplant kidney biopsy at the time showed mild mesangial proliferation, and EM did show some mesangial immune deposits, sort of consistent with some recurrence of her initial disease, but was quite mild, was treated. I believe it's difficult actually to find this in the chart these days, but it looks like her MMF dose was increased for some period of time. A follow-up biopsy in 2008 showed sort of similar findings, actually, but without immune deposits. So she was then treated with her sort of baseline transplant immunosuppression since that time. Other past medical history of relevance, she does have a history of pretty severe asthma and chronic rhinosinusitis, complicated by requirements for multiple courses of antibiotics. She's had multiple surgeries. And in fact, just in the last year has been diagnosed with mild bronchiectasis, thought potentially related. She has osteoarthritis and hypertension. She's never been a smoker, no history of IV drug use. She has owned birds for many years. Medications at the time that she's presenting to me include her immunosuppression, which is at prednisone of 3 milligrams daily. And this is because on higher doses of prednisone previously, even 5 milligrams a day, she complained of edema and worsening hypertension. Her antimetabolite was at a myfortic dose of 180 milligrams twice a day, and her tacrolimus was maintained at a trough of 4 to 6. At the time she saw me, her primary care doctor had increased her candesartan rather dramatically due to this worsening hypertension over the last couple of months. and in fact had been started on a second agent, which was new for her, chlorthalidone. And really, the symptoms she reported were increasing fatigue and some increased sinonasal discharge. Next slide. So on exam, she's hypertensive. Her exam is normal. A transplant kidney duplex ultrasound was normal with the exception of increased renovascular resistance throughout. Her urine studies showed that her proteinuria had increased from a baseline of about 0.5 grams per gram over the last couple of years, now up to 1.5 grams, and in fact, more recently up to 2.5 grams. The remainder of her labs, actually, her creatinine was stable from her baseline, so no change in her filtration function. She did have a worsening anemia. Her hemoglobin had fallen to 9.5. Her serum albumin was normal. Donor-specific antibodies and an allosure were normal. Monoclonal gammopathy workup showed a serum-free light chain ratio that was enhanced for kappa, but only very, very slightly, kappa to lambda ratio of 1.7, and an SPEP and UPEP with immunofixation did not show a monoclonal component, and her complements were normal.
Okay, any questions for Dr. Rivera?
Did the patient have a workup for why she developed recurrent MPGN, like a complement workup? Was it done?
Complement workup like back in 2007?
I mean, or recently, like a full complement panel?
No. Just the secret.
Any other? Okay, so we'll just go right into the biopsy here. People can chime in the chat with questions and comments, and hopefully we'll be able to get to those. So this is a relatively low power view of this patient's biopsy. Over on the center and the left are Jones stains, and then there's a Masson trichrome stain. And one thing that hopefully you'll notice is that a lot of the tubular parenchyma is really well preserved, and that probably goes along with what was described with the preserved EGFR in this patient. And there's really only some focal areas of interstitial fibrosis. The Masson trichrome really, only captures a little bit of this blue staining collagen within the interstitium. But of note, all the glomeruli sort of stand out. And so we see a lot of increased silver staining, and they look plump, as well as with the Masson trichrome, they're more blue and voluptuous than our typical glomeruli. And so we'll move on to just a couple of pictures of the tubular parenchyma here. Again, just focal tubular atrophy and interstitial fibrosis. It's a transplant case, so we're wondering, could this be a rejection? Could this be an allo reaction to the graft? And when we look here, we see that the inflammation is largely retained within areas of tubular atrophy and interstitial fibrosis. There's not really any significant tubulitis. We take a look at the peritubular capillaries here, and they're mostly clean without any leukocyte congestion. So we're not seeing any obvious evidence of a rejection process. When we look at a PAS stain, we notice that one thing that really stands out is there is very prominent arteriolar hyalinosis. And this was actually seen in 2008, and there were also some focal features that would suggest calcineurin inhibitor toxicity has been contributing to this. So we do have this really prominent arteriolar hyalinosis that was actually detected in 2008. And one of the surprising things is that the actual parenchyma, we're not seeing stripe fibrosis or a lot of chronic injury as a consequence of this. So that's another point of interest. The glomeruli we'll look at in higher magnification. And so these are Jones stains, and we can see that these glomeruli all demonstrate prominent mesangial expansion. We see increased silver staining and increased cellularity within the mesangium, and it's variable, but segmentally it's really very prominent. but it can be seen essentially everywhere. The other thing that we can note is that these the capillaries, the glomeruli, are very irregular. So we can't really make out the nice ribbons that we like to see. And we see a lot of irregular silver staining. And in some areas, we see these vague double contours and thickened staining. And then there also appears to be a modest increase in cellularity within some of the capillary loops as well. But it's not associated with frank and more extreme types of inflammatory injury like cellular crescents or segmental necrosis. Here's another view. Again, we see this prominent mesangial expansion and some of the changes in the peripheral capillary walls. And then very focally, we could see this evidence where we have obliteration of some of the capillary loops and attachments to Bowman's capsule. So very focal segmental scarring in the sample, but not no global sclerosis actually in the entire sample that we looked at. So very well preserved tubular parenchyma, glomeruli markedly altered, but only focal segmental glomerulosclerosis without any obvious, without any detectable global glomerulosclerosis. We move on to the immunofluorescence, and we see strong positive staining for IgG that's present within mesangial regions and also in the peripheral capillary walls. So this is very typical for a membranoproliferative pattern of immune complex deposition. We see that there's staining for kappa, but not lambda. So this is consistent with the earlier staining that was reported in the native kidney, as well as the early recurrence in 2007 in the transplant. This is C4D staining that essentially mimics the staining that we see with IgG and kappa. C3 was also present, about a 1+ staining in the same pattern. So there is complement deposition, but it's not, this overwhelming amount of complement. It's detectable in there, but not extreme. We then, based on this patient had never been worked up further in terms of a monoclonal gammopathy of renal significance in the past, and now we have all these reagents available, and so we did IgG subtyping. IgG subtyping showed that the IgG 1, 2, and 4 were negative, but IgG 3 was positive. We then went on to confirm the monotypic deposits doing pronase IF, and we show here that we see IgG and kappa staining, but no lambda staining. So now we both by direct immunofluorescence as well as pronase IF, we show this monotypic evidence with kappa bias, and then the IgG subclass is IgG3, consistent with a monotypic process. The electron microscopy essentially confirms the presence of immune deposits, and they're seen expanding the mesangial regions. And here we can see a capillary loop here, at least some blood cells within what are presumably capillary loops. Looking at the electron microscopy here, I couldn't see any normal capillary walls at all. Here's another lower power picture. We can see, again, some abnormal endothelial cells, some serum proteins here present, and then very, very thick capillary walls that have extraordinary remodeling, increased matrix, cellular processes, as well as these electron-dense immune deposits that are present in the capillary walls and in the mesangial regions. So really very, very widespread changes within the glomeruli. Here's a higher power magnification view showing then thickened subendothelial region with these granular immune deposits that don't have any obvious substructure, and then the glomerular basement membrane, some of the podocytes, as well as the endothelium. And then here we see the hyalinosis in the arteriole, as we saw before. So the final diagnosis for this is now 16 years after transplant. We have proliferative glomerulonephritis with monoclonal IgG deposits, and it's an IgG3 kappa type, and it's recurrent based on the patient's clinical history. And then we really have very focal chronic injury. We have this hyalinosis that could very well be due to calcineurin inhibitor toxicity that was also seen 13 years earlier, and then no evidence of rejection at this point. So I thought I would review how do we validate a monoclonal gammopathy of renal significance. And there are sort of three classifications. One is definitive, and that for definitive, we really need to prove the monoclonal nature of the immune deposit. And this is really to demonstrate that those antibodies have singular variable domains. And this is mostly empirically derived by doing electrophoresis and immunofixation, and it's usually only done in the serum. Sequencing approaches or more in-depth approaches are just not practical. And when you're looking at a monoclonal gammopathy of renal significance, you really should do all of the following. And most people are familiar with that: SPEP, UPEP with immunofixation, serum-free light chains and ratio, and then a bone marrow biopsy and flow cytometry. And if all of these are negative, people even suggest you even go further to look for a clone by doing additional imaging and studies to try to completely exclude the possibility of a lymphoproliferative disorder. So why prove this with immunofixation? This is an example of a patient that was identified or diagnosed with an IgG3 kappa version of PGMID in a kidney biopsy. And then when the immunoblot was done, it was actually determined that it was an oligoclonal process. And here you can see that if you look at the IgG3 immunofixation, you see these multiple discrete bands that indicates there's actually multiple clones present here, and it's an oligoclonal process. So even though by our in-depth workup on the renal biopsy, we would say that this is a monotypic or even a monoclonal process, when immunofixation is done, it unmasks actually that this is truly a polyclonal process. Well, what's the next step down? And this is probably where a lot of cases fall in, and that's probable. And that, what does probable mean? It's, well, we can demonstrate that by the renal biopsy workup that there is a clear light chain bias and a heavy chain restriction. And then we had also, in addition to that, we can map or match that antibody that we see in the glomerulus with the circulating protein. So we actually find that there's actually a circulating monoclonal protein that matches what we see in the kidney. And so there we see that that's a probable diagnosis of MGRS. And then what about possible? And this is where also a lot of them fit in, and especially with PGMID, that's where a lot of these fit in. This is a possible MGRS. And so this is when we can only really define that there's a monotypic deposit based on the renal biopsy findings. So we can't really demonstrate that there's something out there, that there's a monoclonal B cell proliferation or plasma cell component, or that there's a monoclonal gammopathy based on serum or urine testing. So, and this should be, and this is indicative of the case that there's actually like 10% of IgE nephropathy cases appear monotypic, and they probably are not monoclonal, or at least the vast majority of these. There's a lot of fibrillary glomerulonephritis cases that also appear monotypic, and actually most of these are reclassified as polyclonal once you do the further workup. But we also need to remember that there are definitely monoclonal immunoglobulins that do not freely circulate and that are detectable at levels, and they're not detectable, and that's because they're probably prone to precipitation or binding to tissues, and that these pathogenic clones can be challenging to detect. So PGMID, we have non-organized immune deposits. They're present in subendothelial and mesangial regions. They can have a variety of patterns: MPGN, diffuse proliferative glomerulonephritis, membranous nephropathy, as well as mesangial proliferative patterns. They're classified as being monotypic. Most common is IgG3 kappa. Why IgG3? Well, there's some evidence that this may actually, the IgG3 subclass might be more prone to self-aggregation. Of note, only about 30% of patients with PGMID have detectable monoclonal immunoglobulins or a B plasma cell present. so that this is only the minority of cases. We're actually going to be able to say that there's a probable MGERS. Most of them are going to fall into the possible category. And then of note, renal prognosis is poor, but I would also want to note that it's quite variable. So 25% progressed to end-stage renal disease within 30 months of diagnosis, and there's frequent early recurrence in renal allografts, but this is also highly variable. So, 75% don't progress within 30 months. And so this is one of the features, I think, that, points again to maybe the first talk by Jonathan, that, precision medicine is really important because all patients you can't lump under one category. And there is quite a bit of variability amongst individual patients. Pathophysiology. Is it one entity or multiple entities? Well, I think, it's more than one for sure. So there is some of them, clearly appear to be a monotypic or a monoclonal process, but about 20% of these cases are polyclonal. And so these have been actually uncovered using heavy chain, light chain antibodies that represent conformational epitopes. So the monoclonal nature may represent that this is some sort of lymphoproliferative process, but it also could reflect that it is just a biased response to infection, autoimmunity, or something else. And so that has to be taken into consideration. The treatment, it's aimed at suppressing the pathogenic clone, but in many instances, including PGMID, we really can't identify the clone. So for transplantation, recurrence rate is high, as we saw in this patient. Graft loss is common, but it takes time, okay? So 44% in one study showed graft loss at 87 months after transplantation. And then there's some evidence that rituximab treatment in early recurrence could be effective, and patients that underwent this treatment did see some reasonable long-term graft survival. So what about this patient? How would you treat this patient? And I think this is, I just wanted to review the history here. In the 80s, they were actually diagnosed with MPGN, and then they went on to end-stage renal disease and transplantation in 2005. Recurrence was actually documented 2 years later, so relatively early. And here's just an electron micrograph showing that the immune deposits are detectable here in that early allograft. And also of note, the capillary walls look really normal. The patient was treated really with upping the immunosuppressive treatment at that time, but no clone-specific therapy. And a year later, there's actually no deposits detected, remarkably, in the kidney. And again, the capillary walls look normal. So now we're 13 years later, we have a full-blown recurrence, but relatively well-preserved renal parenchyma, other than the glomeruli, which don't look that great. And so far, no clone-directed therapy. So at this, I'll just turn it over to Matt for a follow-up, and then we could also entertain questions.
Thanks, Kelly. And yeah, I mean, this has just been pretty recently that we've found this out. So the immediate, after long discussion with the patient, we decided, given her prior response in 2007 to increasing the MMF, at least initially, our plan will be to increase her myfortic up to at least 720 milligrams twice a day, and try that for a number of months following her proteinuria and hypertension. The next step, if this is not successful, I think would be rituximab likely, but certainly open to others' thoughts and discussion. I'm also open, she does not, she followed with one of the transplant nephrologists who's not at UW any longer, and she's not seen anyone in transplant in probably 10 years. So I'm also open if any of the transplant folks think she should be seen back in in the transplant clinic, I'm happy to think about that as well.
Did the patient get bone marrow biopsy?
I don't believe the patient has ever had a bone marrow biopsy. It's possible like in the 80s, but certainly nothing recently. And that's something I've thought about. And if people feel like that would be a wise move, particularly maybe given this very slightly elevated capital lambda ratio, then I can move forward with that.
PGMID, it's often negative. We don't find it clones.
Yeah, and that's been my reading certainly, and so we haven't immediately done that, but certainly open to doing that. Nikolai says he's unsure of the acute component of the disease here. What would be a target? Proteinuria likely follows the GBM thickening. Yeah, I think the acute component, I think, are two things. One is there's been this dramatic change in her blood pressure control, which has mirrored prior relapses of her disease. She basically had hypertension controlled on like the lowest possible dose of one agent as of like 4 months ago, and now she's requiring 3 agents and is still hypertensive. And then the second thing would be she's had like a 10-fold increase in her proteinuria. That's my only sense of there being an acute component here. But it is true that we don't have any biopsies from 2008 till now. So how long has this process been going on? I don't know.
Matt, I think some partnership with oncology may be useful in the future because, for example, if you're doing MMF and it doesn't work, you may try rituximab and that doesn't work. So it may escalate to a point where, yes, you will probably need bone marrow biopsy and stuff to see if there's any clone. She falls into that 15 to 30% of the people that they do catch a clone, and or use of stuff like bortezomib moving forward. Those kind of things might come down the road.
Bilal, would you refer her for bone marrow biopsy now, or would you wait to see if her markers improve with more traditional treatment?
So she's showing you that she's had this pretty significant recurrence and the proteinuria going tenfold, and hypertension that is getting uncontrolled. So there is a significant component impacting her kidney. So I would say that a full workup should be launched. And here you probably should reach out to Hemonc to get her plugged with them as well.
Thanks, Paul.
I would add that maybe getting an idea of what her disease is responsive to now might help for the future, because she's still young and maybe has another transplant in her future. And there's some evidence, although it's not conclusive, that treatment with rituximab and controlling the disease prior to transplant may improve outcomes. And so, figuring out, whether or not this patient's disease is responsive to Ritux or an anti-plasma cell type therapy might help, extend the life of this transplant, as well as maybe put her in a better place for a second transplant, if that is what's going to be in her future.
And also echoing what Bilal said, if we get a biopsy, bone marrow biopsy, and if there's a clone, we can do clone-directed therapy, as opposed to throwing all the agents. We could throw all of them at the same time, or do Ritux followed by bortezomib. It's plasma cell therapy plus steroids.
Thanks for everyone's thoughts. Appreciate it.
Okay, I think we ended up exhausting our time. I think there was a last short show and tell case, but maybe we'll hold that for future meetings. How does that sound?
I will leave that for the next topic.
Okay.
Fantastic.
Great. Well, thanks so much, Ram, Kelly, and David, and everyone for joining. So we will see everyone next week. Have a good weekend.
Bye. Bye.